Hi, welcome to class number 12. We're going to continue with our discussions of therapy, which we will be doing for the rest of the semester. We're going to take a little bit of a detour right now and discuss some things that are perhaps certainly therapeutic, but perhaps the political side of therapy. It's hard to get away from politics in this world, and aphasics are no different from that. There are a number of organizations that exist that represent people with aphasia and people with stroke. One of them is this World Stroke Organization that you see in front of you. And they have designed something that's called a Bill of Rights. I'm not going to dwell on this. You're more than capable of reading this on your own. I just want to highlight a couple of issues. Things that people with stroke feel they have a right to. And I'm not contesting that even for a second. They feel they have a right to receive the best stroke care that's available, and that they really should not have to compromise, which means we have to be the best stroke care providers as possible. It's one of the areas of speech pathology. I'm not sure there isn't any area that isn't different from this, but it's certainly an area where one should not take a patient and say, well, I'm a certified speech pathologist, so I can work with an aphasic patient. Have I ever done that? No. Have I ever read about it? Well, yeah, I took a course, in my master's program, but it's been 10 years since then, and since then I've been working with children in school, adult stutterers, cleft palate children, whatever, but not people with stroke. Then that's not a good time for you to take on a stroke patient. You need to retool to come back to it. You need to be able to provide the best stroke care possible. For that, you need to be prepared. We need to be informed, and we need to be able to support people in their recovery. And what support we cannot provide, we have to know where that support is available. Whether that means you have to know a social worker, or whether you have to know organizations, you have to know about healthcare provision. And again, we don't need to know everything, but we need to know where it's available and the person who does know. Okay, so again, I encourage you to read this slide carefully and think about it. One of the things we don't think about often is the impact that aphasia has on social activities. One could easily imagine that with the inability to communicate, social activities are diminished if they don't disappear. This is kind of a survey. If you look in the bottom left, you'll see it was done at Dartmouth College, but it could have been done anywhere. And what we're asking patients, and these are kind of results, during the past month, during the past 4 weeks, has your physical and emotional health been limited, both with family, with friends, with neighbors, or with groups? And what we see is that it's been extremely limited for many, somewhat limited for fewer, moderately limited, slightly limited. All different kinds of responses are available. But one can imagine that this has much to do with two things. One is the severity of the communication disturbance. The more severely the person, or the less the person is able to communicate, obviously they're less able to socialize and they're less able to integrate and to communicate. Second, along with that, probably, is the physical disability that comes along with it. And so the person who's in a wheelchair, who's hemiplegic, who is incontinent, even if speech and language is equal to someone who has none of those issues, who is mobile, who has no hemiparesis, who is not paralyzed, who is able to walk. So all those things would be working with them, but clearly, the more different you are, the less you're able to socialize and to integrate. In our case, we're mostly concerned with the communication disturbance. People don't socialize with people who can't communicate. That's clear. No one contests that. But how can we help? And I don't have a quick answer for you. It's something that we need to keep in mind. When we're concerned about why is our patient depressed, why is our patient withdrawn, why is he not participating, we need to think about those issues as well. Okay, and by the way, its impact on the family. Okay, so even if the patient is not able to communicate, or if he's moderately impaired in communication, how willing is the family to bring that patient to a social event, to take them to a wedding, to take them to church, to take them to synagogue, to bring them shopping, to go to some kind of a meeting that's been scheduled in the community, family parties. We often have said the phrase that stroke is a family problem. It doesn't just affect the individual, it affects all the people who are around that patient as well. Okay? And here we're focusing on the social isolation that often exists as a result of aphasia. Okay. I'm really not going to dwell on this even for a second. This is replete with information, but stuff for thought. I would really like you to read this, and I'd like you to think about these issues. Okay. Okay, and I'm not going to dwell on this at all. Think about this because I'm going to make this as part of your discussion group assignment. Okay, thinking about client-centered aphasia services and how we can perhaps better what we do to make it more appropriate. Okay. What do persons with aphasia want? What do they want from us? What do they want us to do? Well, this is based on a number of surveys that have been done, both with patients and with families. And basically, this is what they're telling us that they want. Okay? A, they want to be able to communicate better. All of it's fine, but that's certainly fine because that's what we want to do, right? We're speech-language pathologists. Our job, our focus is communication, and we want them to be able to communicate better. So we have no trouble with this first one at all, to the degree that we're able to do this. Okay. Second, and here's where it starts to lose a little bit, where perhaps it's not always so obvious, but this is the case. Patients want information. They want to obtain information regarding their status. We don't always routinely do that. We're good, perhaps, at doing therapy. So we come into our session and we have our lesson plan and we have our materials and we know exactly what we want to do and we have our short-term goals and long-term goals. We have our goals, but we don't often share what it is that we're doing. We just do. Okay? And patients want information regarding their status. They want to know how well they did. We don't always tell them that. Not intuitively, not routinely. They'd like to know, did they do well today? Did they do better than expected, worse than expected, exactly what was expected? How far are they from getting well? Are they on the right track? They'd like to get feedback. They want to get feedback, and they don't want to get an attaboy. They don't want to just say, hey, you did a good job, great. Some information regarding their status. They'd really like to know how they're doing. Okay? They want lots of therapy. They don't want it once a week, and they don't want it twice a week. They want excellent therapy provided by experts. They want lots of it, and they want it immediately. They don't want to wait a month or two before therapy starts. They're not interested in saying, well, there's spontaneous recovery, so why don't we let that kick in first? We're going to talk about that, if that's really a viable plan. And should we be doing that? But the patients don't want us to do that. They don't want us to sit back and say, we're going to start therapy in a month. In the meantime, you just get better and you rest and you get stronger and you're going to recover somewhat anyway. And so, we're going to start. No, it's not what they want. They want therapy. They want it now. They want a lot of it. Okay. They would like some control and they'd like some independence. They trust you to call the shots, but they are the customer. And no matter how impaired they are the customer. And they want some level of control and they want to be able to make some decisions. We tend not to really include them in any of our plans. We decide they're going to get therapy 3 times a week for 45 minutes, and our goals are such and such. Do we check that out with anybody? Or we become kind of control freaks, and we're independent, but we're the provider. They are the customer. They like to have some control and independence as well. Obviously, we want to be able to convince them that our plan is an appropriate plan. On the other hand, we have to be willing to compromise somewhat also, if in fact that's within the level of professionalism. Patients feel like they've lost dignity, they've lost respect. It's very hard to take an adult who has been even an average intelligent adult, and we're not talking about someone necessarily who is a full professor or a judge or a doctor, talking about a person with a high school degree who has a job, 40 hours a week, and they get paid, and they do what they do, whatever it happens to be. But they have this level of dignity and respect that is appropriate to their status in life. And when they have a stroke and when they have aphasia, that's wiped out. They feel totally disempowered by their aphasia. No one asks them questions anymore. No one consults with them. No one gives them choices. No one asks them when they want to eat, what they want to eat, when they want to have therapy, what they want to do in therapy, what they're going to wear, what are they going to watch on TV. No one's asking. No one's asking. And they're unable to actually become, to be independent and say, hey, talk to me, ask me, because they can't do that either. And so we need to kind of preempt that. We need to be able to ask families and ourselves, consult with the patient, talk to them, see what they would like. Okay. In terms of social and leisure and work, all these relationships are impaired. They might never be back to normal, and that's not an unlikelihood. But we need to keep that in mind, and we need to prepare the patient for that. That doesn't mean that just because it's impaired, it's absent. There should be a social relationship and a leisure relationship. Work, if possible. It's probably the last thing that's likely to happen. But we need to pay attention to these things. Okay, we're going to stop here and pick up